All right. Okay, we're going to start again. Okay, we're going to move on to our next topic of presentation, which is CNS complications in endocrine emergencies. The speaker today is Dr. Chew Ken Tseng. Okay, he is an endocrinologist and internal medicine specialist in Hospital Sultan Ismail in Johor Bahru. He's graduated from IMU and then he obtained his MRCP in 2017. And then after that, he underwent his fellowship in endocrinology training between 2021 to 2023. Okay? Based on his career history, he has been in a lot of hospitals throughout Malaysia, in Perak, in Perlis, Penang, and also last but not Pahang as well. And then lastly, and currently in Johor. Okay, without further ado, I give you the floor to you, Dr. Chew.
Okay, thank you so much, Dr. Is, for the kind introduction. So my task here today is to talk about CNS complications in endocrine emergencies. And so I guess let's get started. Okay. All right. So the endocrine system is not confined to one organ. It involves many different glands. One of the oldest definitions of hormones is that it is a substance produced by glands with internal secretion to carry signals through the blood to target organs. This means that hormones are often produced in one place, having effect on other places. So this means that hormones can have systemic effects, and it is no wonder that it can have CNS manifestations. So on the right, you can see the endocrine system has many different glands. From the top, the hypothalamus and pituitary, to the pineal gland, and the parathyroid, thyroid, the thymus, pancreas, the sex organs, the adrenal, and placenta during pregnancy. So however, if you're going to zoom into, because we're talking about CNS complications and something acute, probably the one essential for lives would be these four things that I put in the box, which is the hypothalamus, pituitary, the thyroid, parathyroid, pancreas, and adrenal glands. So there's a lot to go through. So I've identified some of the emergencies that can occur in certain situations, certain organ systems. The first for pituitary will be pituitary apoplexis, followed by the thyroid, which will definitely with the extreme ends of thyroid storm and myxedema coma. Again, the calcium, the other end would be hypocalcemia, and the other end would be hypercalcemia. Glucose, we talk about hyperglycemia, would be DKHS, hypoglycemia, and the adrenal will be adrenal crisis. So for the first case, I have a 34-year-old man who was well with no medical illness. He initially presented to the ophthalmology with sudden onset of right eye blurring of vision for 2 days. On examination, he noted that he had a right eye temporal hemianopia. He had no ophthalmoplegia or any other cranial, neurological signs. So urgent CT scan was done, and you can see this. From here, you can see the sella. This CT scan shows that the sella turcica is actually enlarged. So this is consistent with a pituitary macro adenoma. And as you see over the superior side of it, you can see a hyperintensity, which was consistent with a bleed. And you can see just above this macroadenoma, this is where the optic chiasm is lying. So as the bleed actually impinges on the optic chiasm, it is no wonder that the patient had a temporal vision loss over the right side. So he was subsequently started on IV hydrocortisone and underwent a transsphenoidal surgery. So I tried to portray to you a case of actually a pituitary apoplexy. So pituitary apoplexy occurs when it's abrupt pituitary infarction or hemorrhage, most commonly hemorrhage. And you have probably heard of the syndrome called the Sheehan syndrome, which occurs in postpartum women who develop postpartum hemorrhage due to the large amount of blood loss resulting in hypovolemia and hence infarcting the pituitary gland. But however, this pituitary apoplexy can actually occur in many other situations as well. It's a rare condition occurring about 6.2 cases per 100,000 people or 0.17 per 100,000 people per year. It can occur at any age, but mostly the age of 50 or 60 years old with a slight male preponderance. And on the right, you can see the pituitary gland is actually a very vascular, organ. And I think it is the only other portal system aside from the liver. meaning that there is a vein, the two capillary bits are joined by a venous system. So in pituitary apoplexy, 10 to 40% have precipitating factors. Often because you have done a form of angiography, or the patient had some form of head trauma, or perhaps surgery, or a form of dynamic test. For example, endocrine, we do certain dynamic tests such as the insulin tolerance test, or GnRH therapy, dopamine agonists, and anticoagulations. So this results in either perhaps resulting in occlusion of the vessels due to perhaps vasospasm, or perhaps the patient had underlying macroadenoma, and because we stress it with a dynamic test, it results in high demands from the pituitary gland. It results in infarction or perhaps anticoagulation itself. Most of the patients actually have underlying pituitary adenoma. However, most of them are actually unknown. 75% of pituitary patients with pituitary apoplexy don't even know they have pituitary adenoma itself. And it makes perfect sense, because when you have a macroadenoma, that means your pituitary is larger than normal. So this explains why the pituitary gland requires more oxygen or nutrition demand compared to usual. And the little triggering factor that can cut off the oxygen or blood supply to it will result in infarction. Mostly it is occurring in non-functioning tumors. Sometimes case reports have reported it happening in macroprolactinoma or acromegaly. So the clinical presentation of pituitary apoplexy is truly related to either the sudden reduction of the pituitary hormone production, which is causing hypopituitarism, or pressure on the surrounding contents. On the top right-hand corner, you can see this is a pituitary gland. On top of it is an optic chiasm. So compressing the optic chiasm can result in visual field impairment and deficits. And you see surrounding is the cavernous sinus, and you can see there's the intracavernous part of the carotid artery. So if there's compression and resulting in maybe a vasospasm or this intracavernous carotid artery, it can result in hemispheric signs such as hemiplegia. And you can see over here, we have the cranial nerves 3, 4, 6, as well as V1 and V2. And compression of this can lead to optic nerve palsy and probably some numbness or pain over the face. And sometimes, because it's a macroadenoma, it invades into the sphenoid sinus. So that's why sometimes the patient can have CSF leakage as well. And of course, any bleed can actually result into the subaortic space, can result in chemical meningitis. So the most common symptom of pituitary apoplexy would be headache, 80% of them. It is one of the important differential diagnoses, and a patient comes in with a thunderclap headache. It's often retroorbital, but can be frontal and diffuse as well. The next most common symptom would be visual field disturbances. In as many as 50% have visual field disturbances. And of course, the visual field disturbances will, of course, depends on the location of where the blood tracks and impinges along the optic tract. So I think as we have seen earlier, just above the pituitary gland is actually the optic chiasm. So often we have temporal hemianopia. It compresses it completely, we have bitemporal. If it compresses to one side more than the other, probably is just one side developing hemianopia. But sometimes you can go track along the optic tract to the nerve. So that's why you can have a loss of visual field over one eye and the other eye is unaffected. So oculomotor palsies are common as well in up to 52% of patients, and one of the more common nerves to be impinged should be the third nerve. So the other thing that can occur is actually hypopituitarism. As we know, the pituitary gland is a master gland of all the endocrine glands throughout the body. So posterior pituitary would be our ADH and oxytocin. Oxytocin probably not too important, but ADH is what controls the reabsorption of water at the renal tubules. And then the other anterior pituitary hormones that we have will be the sex hormones, the thyroid, the prolactin growth hormone, and ACTH. So the most common deficit, most important deficit will actually be hypocortisolism. And this will result in hypotension, hyponatremia, hyperkalemia, and hypoglycemia. As in why hypocortisolism is the most important, even though you have other hormone deficits such as hypothyroidism, hypogonadism, it's because loss of cortisol hormones acutely is the one that's going to cause problem. Because when you lose the cortisol immediately, that's when cortisol starts to crash and develop adrenal crisis. For example, in terms of thyroid, the half-life of thyroxine hormone in the body is about 1 week. So you acutely lose your TSH is not so bad because your body is still able, the leftover thyroid hormones is still able to last you for a few more days. And hypogonadism, though it is troublesome, but it does not cause any threat to the life. So when you're dealing with hypopituitarism, the most important hormone to detect and treat first is hypocortisolism. So that's why in adrenal crisis, in pituitary apoplexy, even when the cortisol hormone levels are normal, we always start the patient on IV hydrocortisone first. Why? Because pituitary apoplexy is a dynamic condition. Just because the AM cortisol you check at that moment is normal does not mean it's going to be normal in the evening. The bleed can just worsen, in the matters of few hours, resulting in hypocortisolism. So in pituitary apoplexy, always treat a patient with steroids, even though you have evidence that the cortisol is still adequate, because it may be inadequate in the next few hours. Okay, so this is just to show that the diabetes insipidus is rare. It is because while the anterior pituitary hormones are produced in the anterior pituitary itself, the posterior lobe of the pituitary glands actually acts as a storage area rather than a factory. The ADH is actually mostly formed at the paraventricular and supraoptic cells over the hypothalamus. So by destroying some of the posterior pituitary, you're just destroying some of the the depot, some of the storage area, but the factories are still unaffected. It is said you need to lose about 70% of this neurosecretory cell in hypothalamus. So it usually has to be a very large tumor extending supracellularly, destroying part of the hypothalamus before diabetes insipidus can occur. But of course, post-surgery, it can also occur quite often because you disrupt this pituitary stalk. So as we mentioned, one of the most common presentation of a pituitary apoplexy will be headache, which some people describe as thunderclap headache, visual disturbances, and ophthalmoplegia. So I think these are some of the most important differential you must consider. Subarachnoid hemorrhage, look for any evidence of meningitis or infection, cavernous sinus thrombosis, and a midbrain infarction. So that's why I think the most important investigation is always to do imaging first, because that is where, when you do a CT brain, you can look for SAH. And this is also where, when you do a CT brain, you can get an idea, look at the cellular region, whether there's a pituitary enlargement. As we say, about 70% of pituitary apoplexy actually occurs in macroadenoma. So in this case, when you can see the cellular testicle is already enlarged, you can suspect, oh, the pituitary gland is actually not normal. And then most commonly, pituitary apoplexy is actually hemorrhage. So we can see hyperintensity on the CT scan, such as the image shown on the right. So, but the sensitivity of CT scan can be variable, mostly because the hyperintensity can decrease in time, and sometimes you can have the uncommon pituitary infarction instead. So I think if you do a CT scan first, you want to rule out things like SAH first and look for clues like pituitary enlargement. Once you rule out SAH, you suspected that there is pituitary enlargement that can be a pituitary apoplexy, then you proceed with an MRI, which is actually our imaging of choice. Of course, you can do it immediately, that would be great, but I think in our setting, we probably should do a CT scan first. So just to remind everybody, blood clots changes with time. So that is why when you see in the image on the top left, bottom left, sorry, in a CT scan, blood, hyperacute, acute blood can appear intense. And there are differences in the intensity in T1 and T2 weighted images, depending on the, how acute or how chronic the bleed is, because of the methemoglobin and the oxyhemoglobin, the changes of the breakdown products of the blood. So just show the example on this image. CT scan on the right, the above is T1 weighted, below is T2 weighted. T2 weighted because you can see CSF is bright. You can see that maybe picture might be a little bit small here, but you can see that T1 weighted, there's a little bit of hyper intensity at the pituitary gland. And you can see here there's hypo-intensity here. So this is consistent with acute, early subacute bleed in the pituitary gland. And you see the next image, you can see that there's a very big pituitary gland, and you can see it's so big over here, big around it. And you can see it's intense in both T1 and T2 weighted. So this is probably a little bit more subacute or late subacute kind of bleed. And one very interesting sign you can see over here, a circle over here, is called the sphenoid mucosa thickening. This is another example of sphenoid mucosa thickening. It is believed it's because the sphenoid sinus is just below the pituitary gland. So because of irritation, it causes inflammation. The sphenoid mucosa is thickened. Another possibility is because there's infarction resulting in venous congestion of the sphenoid mucosa. So it appears a little bit thickened. And you can do a diffusive weightage imaging to help you diagnose ischemic pituitary apoplexy. So the management, if anything in ED, I think if suspect apoplexy, don't think so much first, give steroids first lah. But if, of course, before you give steroids, you can take the AM cortisol, that would be great. If not, just straight away give IV hydrocortisone. No need to wait for the cortisol result. Cortisol result is low, I will treat. It's high, also I will treat anyway. So just cover the patient with steroids if you suspect apoplexy. As we mentioned earlier, pituitary apoplexy is dynamic. Just because it's normal now, it may not be normal later on. Other hormones can kind of wait lah. You just call your endocrine, then let them decide what other hormones you want to replace. If anything, I might replace some thyroxine, but other hormones really can wait, later on until the surgery is done. So there is some discussion whether pituitary apoplexy should undergo surgery or conservative. So we will probably go to the side of surgery if it is severe, until it affects the consciousness, vision, or ophthalmoplegia, because we hope by decompressing the pituitary fossa, there's a less compression, it can help to save some of the patient's vision, as well as also decompress the the compression on the cranial nerves inside there. But just to share with you, there's actually a scoring system. On the top right-hand corner is called the pituitary apoplexy scale, and the bottom is called the pituitary apoplexy grade. These are some of the things that can help you decide whether probably I should do surgery rather than just sitting and wait. So if let's say the pituitary apoplexy occurs, but it didn't really affect the patient much, the vision is fine, there's no ophthalmoplegia, you can probably treat conservatively. But if it has affected the patient greatly, you can see as, for example, the level of consciousness, the lower the GCS, the higher the points. The visual acuity, the more is involved, the higher the points. More visual field deficits, the higher is it, the worse is it, the higher the points. And the presence of ophthalmoplegia, the higher points if it's affected on both eyes. So there's no cutoff points that say like certain points, like maybe 5, 6 points you should do surgery, but it's just a guide to show how severe the apoplexy has resulted in complications. Yeah. So just to share with you, there's one of the studies done to compare whether surgery versus watch and waiting conservative management. This is one of the best evidence that we have so far, because this is a prospective study involving 100 patients. However, it's observational. So it means that, it's still based on whether surgery is done or not, still depends whether the surgeon feels the patient and endocrine feels the patient needs surgery. So obviously, patients who underwent surgery are patients who had worse visual fields and higher PAS scores. So this shows you that on the left-hand side, it shows whether the differences in the hormonal recovery, whether you do surgery or not, and right-hand side for the differences in the visual field and oculomotor palsy. There's actually no difference in outcomes. But I think arguably some people will say it's because patients who underwent surgery, you have already selected them, they're actually worse patients. So maybe you have prevented them from getting worse because of that. Yeah, but what I'm trying to paint to you is watch and wait conservative treatment in pituitary apoplexy is actually a possible path of management, especially if the patient's eyes and nerves are all still fine. Yeah. Okay, so in summary, pituitary apoplexy, patients present with severe headache, visual disturbance, and ophthalmoplegia. Imaging is important. The differentials we have discussed earlier. Most important steroids is the cortisol, so always replace the patient with steroids. And the discussion of surgery versus conservative, I guess you will probably just already refer to your surgeons at that point in time. So let your surgeons, your endocrinologists make the decision on that. Okay, so we'll move on to the next organ system. So case 2, I have a 69-year-old lady with underlying hypertension. She was brought in the family for reduced consciousness for 1 day. Apparently, she has already been bedbound for the past 3 years, and they were unable to get much history from the patient because her GCS was poor already at the time, was E1, V2, and 5. As you can see, the blood pressure is low, 84/62, but surprisingly, the heart rate is not tachycardic for this kind of blood pressure. It's 63 beats per minute. Temperature documented is 36.8. SpO2 is slightly on the low side, 92% under room air. Pupils is too sluggish. Documented, somebody say she might have some neck stiffness. Upon examination, there was reduced entry of the left, middle, and lower zones. The glucose at that point of time was 5.4. Patient has a slight, elevated white cell count, predominantly neutrophils. And when you look at electrolytes, there is a little bit of hyponatremia. Urea and creatinine were normal. And on the ABG on oxygen, you can see that the PO2, probably patient got some hypoxia, PO2 of 82 or face mask oxygen 5 liters per minute. But what's striking, you can see a CO2 retention, PCO2 of 61. Because of the drop in GCS, they did a CT brain, but nothing really striking aside from this multifocal infarct. And this was a chest X-ray done for the patient. So initially, somebody commented it's a little bit hazy, but I guess clearly you can see here, actually, this patient has a very big heart. It's quite big cardiomegaly. So initially, when it was admitted to the ward, patient was treated for meningoencephalitis, and somebody commented wider mediastinum for investigation. However, this is where things get interesting. The physician in the ward actually saw, patient actually have a thyroidectomy scar. Then I tried to dig up the history and say, actually had goiter, underwent total thyroidectomy in 2015. Defaulted follow-up and medication for 2 years already. So this is where I think it gets very difficult for ED. A lot of times we say patient has known case or this, known case or that. And it gets so tricky is sometimes that, nobody offers you any history. You don't know this, obviously when you know the patient had, this history or defaulted, thyroxine, you already suspect mixed edema coma. But, sometimes things are not so easy in the emergency department. So true enough, the stat TFT shows elevated TSH at 66. 54 is so low, almost undetectable. And the echocardiogram showed a left pleural effusion, and patient had pericardial effusion, no RV collapse. So diagnosis was revised to mixed edema coma. So I just go through a little bit on the thyroid. So mixed edema coma is basically the other end of spectrum of hypothyroidism, severe hypothyroidism leading to decrease in mental status, hypothermia, and other symptoms relating to slowing function of multiple organs. Basically, hypothyroidism resulting in perhaps you can say target organ damage. So it occurs about 1 case per million per year, so it's quite uncommon. It is easy to diagnose this if the patient tell you you already know the patient has hypothyroidism, then it came in this constellation of symptom, but it gets tricky when you do not know that patient has underlying hypothyroidism. So this is where you can quickly have a look at the neck, see any thyroidectomy scar. But if you can, of course, you want to get the history whether the patient already has hypothyroidism before this, underlying any RAI before. And certain medications such as amiodarone and immune checkpoint inhibitors can also cause hypothyroidism. So there are often precipitating factors such as exposure to cold, infections, trauma, burns, medications such as opioids, perhaps a stressor to the body such as a stroke or MI. Such as patients by the decay and thyroid storm, they always have a precipitating factor. But what's interesting is the exposure to cold. Anecdotally, my senior consultants always say they often see the mixed edema coma occurs during the cold season. Now it's a rainy season. So this patient actually came to me about 1 or 2 months back. So probably exposure to cold. One very interesting thing is sometimes patients like to ask you, I got thyroid problem, whether I can take any pantang larang makanan. So any what food you should avoid. So this is one case report in the NAGM due to mixed edema coma due to the injection of bok choy. But this is actually a very extreme example because this 88 years old Chinese lady took a few kilo, 1 to 1.5 kilo of raw bok choy daily for many months because they think she will help her diabetes. So she can mixed edema coma. So this is an extreme example. Yeah. So, for mixed edema coma, I'm sure you're familiar with the Bush-Watowski score for the thyroid storm, but mixed edema coma also we have a scoring system. So basically, it's just to help you, to tell you that, there are constellation of symptoms of hypothyroidism. So we talk about thermoregulatory dysfunction, hypothermia, the CNS presentation. The GI symptoms in this case is more for, constipation or decreased intestinal mortality. Precipitating event, whether it's present or not. Cardiovascular dysfunction would be things like bradycardia. So it was unusual, a patient with heart rate of 63, but the patient was so unwell and has hypotension. So that's quite unusual. So that probably should, make you suspect something is off already. Whether the patient have any ECG changes or any effusion in the heart or the lungs. And the metabolic disturbances of, what do you call that, a hypothyroidism. I think you probably know hyponatremia, hypoglycemia, hypoxemia, hypercarbia. So actually, the patient had all this. Yeah. Okay, so yeah, so CNS can be a presentation in patients with mixed edema coma lah. So the word coma is also in the name already. So it can be something you should look out for. So the management is that clinical suspicion is very important. So like I said, it can be difficult if you don't have history lah. So try your best to get as much history as you can. Look out for possible, thyroidectomy done before and so on. Management would include referring to ICU. You send a TFT and also serum cortisol if and do not need to wait for results while waiting for this, because results will take some time. So you kind of treat the patient first. Later on, a few hours later, or maybe the next day, you got results. Then you need to trace it back and see whether it is confirmed or not. Why serum cortisol? You might wonder is because cortisol is quite closely related to thyroid. Why I say closely related is because if the cause of hypothyroidism is in the brain, which is the pituitary gland, so it has, for example, patient have a pituitary surgery before, and the thyroid already is affected. So it is no wonder, no surprise if the cortisol axis may be affected as well. So you do not know, so you probably want to cover for it. And thyroid conditions mostly are autoimmune. So again, no wonder that the patient might also have predisposition to autoimmune destruction of the adrenal, resulting in adrenal, Addison's disease. So if you do not know anything, you probably want to cover the cortisol as well. But I think one of the most important thing is that patient with coexisting hypothyroidism, hypocortisolism. The hypothyroidism actually protects the patients from adrenal crisis, because when your metabolism is slowed down, whatever leftover little bit of cortisol stays in the body and can help to still sustain the patient. However, if you normalize the metabolism, whatever small little amount of cortisol left over are now broken down because of normalized metabolism. This can actually trigger adrenal crisis. So that's why in patients with mixed edema coma, we cover both the patient, not only for the thyroid, but we also cover and with steroids as well. Yeah. Supportive treatment, we give passive warming. We do not do active warming because it is said that the sudden vasodilation can cause cardiovascular collapse. Ventilator support is required and treat the precipitating causes. So so like we mentioned, aside from the thyroxine, what's important would be the steroids. So we treat patients IV hydrocort for the patient. So and the thyroxine, preferably what we prefer is actually IV thyroxine, because hypothyroidism, mixed edema results in edema in a lot of places, including the gut. So when the gut has edema, the absorption of oral thyroxine is actually a little bit poorer, so it can be very erratic. So if possible, you want to give IV thyroxine and not oral thyroxine. And you got IV T3, you can give it as well, because T3 is the active form of thyroxine, right? T4 is the carrier form. So T at the peripheral, T4 is considered T3, and T3 is the one that enters the cells and increases the metabolism. So you got T3 available, then you give lah. So going back to our case, if you look at the scores, actually the patient scored very high. The mixed edema coma score was actually 95 lah. We started patient on IV hydrocort for the patient, which was later stopped when the AM cortisol turned out to be quite high. We started patient on some dextrose-containing strips for the concerns of hypoglycemia. We also referred to the patient for ICU lah. But alamak, my place is actually a relatively new endocrine service. I do not have IV thyroxine. Not many places have IV thyroxine. So this is quite troublesome. So what I did was actually based on this paper lah. Oral thyroxine is actually possible. I loaded a patient with oral thyroxine 500 mg stat and then maintenance. So in this study, it says that it is possible to try a patient on oral thyroxine. So I think the biggest concern that you have when loading a patient with so much thyroxine, be it IV or oral, would be if the patient has underlying ischemic heart disease, you might trigger a heart attack. Because when you have hypothyroidism, you slow down the metabolic demands of the whole body, including the heart. So when you try to normalize it, the patient probably have underlying atherosclerotic disease, can trigger a heart attack. So if patient have underlying IHD, you might not want to load the patient with so much oral thyroxine. So I given the patient oral thyroxine and then I tapered it down, and fortunately, patient improved. You can see probably after a month later, the TFT has normalized quite well. Even with enough inotropes and oxygen, GCS also improved. However, upon discharge, I was unable to bring back the GCS back to full. She was still requiring nursing care and SOP feeding. So, let's go to case 3. So I've got 18, this is just a short case, 18 years old lady. She had underlying grave thyrotoxicosis since 2015. Has positive thyroid antibodies. I don't have the TSH receptor antibody, but anti-TPO is elevated. And at the point in time, she was a carbimuscle 20 mg/OD. I didn't put it down here, but back in 2018, she actually defaulted her carbimuscle. And at that point of time, she had a history of admission because of auditory and visual hallucinations, which resolved after her carbimuscle was restarted. So because of this, relapse, we decided the patient required radioiodine therapy. So she underwent RAI in November 2021. And before RAI, we tend to withhold carbimuscle a week before so that the thyroid can take up the radioiodine better, increase the efficacy of the radioiodine. And then we started it a week after the RAI. However, in December, the mother noted the patient started having behavioral changes. She complained of increased forgetfulness, blank stares, and auditory and visual disturbances. And she went to ED, she was clinically thyrotoxic, CT scan was actually normal. And just assuming this was the pattern. So the patient underwent RAI. You can see the free T4 before RAI was 15.6, which was normal. I think normal range for this back in Putrajaya was 11 to 22. And then when she was admitted at the time, the free T4 is high as 55.4. So for this patient, we did not treat the patient for thyroid storm as the other features did not fit in thyroid storm. But we treated the patient with PTU because we were hoping that we tried to block the peripheral conversion of T4 to T3. At the same time, we believe that there's a component of thyroiditis because after RAI, the inflammation of the thyroid gland can result in destruction of the thyroid gland, releasing the preformed hormone. So we started some prednisolone for the patient as well. Psychiatry did help us with some antipsychotic. And after with time, we can see the free T4 start to fall after a period of a couple of months. And then a patient's symptoms has resolved as well along this time. So I didn't treat patients with thyroid, but just to illustrate to you that thyrotoxicosis also can result in a neurological manifestations. So thyroid storm is more common than myxedema coma, about 0.2 to 0.76 cases per 100,000 person years. This life-threatening condition is characterized by severe manifestation of thyrotoxicosis. So there's no free T4 to make diagnosis. You don't need a free T4 to make a diagnosis, like saying, free T4 of 50 is storm, 60, 30 is not storm. Not really. As long as the free T4 is elevated, the patient can have thyroid storm if there's any evidence of target organ damage. And some of the scoring systems that we use is the Bersch-Rutowski and Japan Thyroid Association. Locally, we use the BWS a bit more because it is said to be slightly more sensitive than JTA, but no harm using the JTA scale as well. So in up to 70% of the patients have precipitating factors. So one of the more common causes would be the discontinuation of anti-thyroid drugs or patient defaulted, followed by infection and so on. So I think everybody probably is quite familiar. This is the Bersch-Rutowski point scale. So similar to the mixed edema coma, you look at the temperature, the cardiovascular, any precipitating factor, GI symptoms, and CNS disturbances. And a score of more than 45 is considered a thyroid storm. But I think one of the caveat using Bersch-Rutowski score is because so many things actually overlap with this presentation. Anybody with infection, for example, and sepsis also can have a high Bersch-Rutowski score. So your clinical suspicion is also very important. Okay, so yeah, CNS presentation. This is the one by Japanese Thyroid Association. So in the Japanese Thyroid Association's scoring system, the patient must have clinical biochemical thyrotoxicosis. Free T3 and or free T4 must be elevated. At elevated what point in time? Not important, as long as it's elevated. And you can see that the presence of CNS manifestations is very important. So when this results in actually two scores, TS1 and TS2. TS1 means that it is probable thyroid storm. TS1 is thyroid storm. TS2 is probable thyroid storm. So you can see the presence of CNS manifestation is actually very important in the Japanese Thyroid Association. So you got thyrotoxicosis, CNS manifestation, plus another one more feature is already enough to label it thyroid storm already. If you don't have CNS manifestation, you need more features to support your diagnosis of thyroid storm. Okay. So the neurological manifestation of thyroid, thyrotoxicosis can be quite wide-ranging lah. So just to quickly run through cognitive dysfunction, seizures, tremors, chorea, stroke, myopathy, polyneuropathy, and so on. But I think one of the things that you might want to consider is there's something called apathetic hyperthyroidism in elderly. So elderly patients, when have high levels of thyrotoxicosis, they can become apathetic instead, become more quiet, more stuporous. Yeah, so that's one of the things you must bear in mind in elderly. Manifestation can be different. Okay, so because we talk about seizures, so probably I just went out to look at the literature, how commonly seizures occur in thyrotoxicosis. Actually, it's very rare. In this retrospective Korean study, it only occurs in 0.2% of the patients. Yeah, so seizures are quite rare, but it's possible. Like what kind of seizures they have? You probably can see character of seizures is mostly GTCs. Okay. So, management of thyrotoxicosis, again, if you've got prior history, perfect, it will help you make the diagnosis easily. But if you do not have, which sometimes occur because it's either a newly diagnosed thyrotoxicosis or the patient is so unwell, it cannot offer you any history, just quickly examine the patient. Does the patient have goiter, got thyroid eye signs, and clinically is very thyrotoxic or not? That would help you. You send a TFT step and start treatment first. Do not need to wait for results. Treat first lah. Then later on, when result available, then we pull back the diagnosis. Of course, other things will be ICU referral and supportive care, fluids, temperature, and electrolytes. Okay, so just to quickly go through medications that we give would be PTU, carbimazole. One of the questions people always ask me is PTU better than carbimazole? Some people prefer PTU because it said PTU inhibits the peripheral conversion of T4 to T3. Carbimazole don't have that. So PTU have a slight, advantage in that sense. But I didn't put it here, but a lot of studies say that probably there's no difference. Some Japanese studies say probably no difference. It's because you're going to start a bunch of other medications that would inhibit peripheral conversion, such as beta blocker and steroids. So it is not wrong to give carbimazole, to be honest. Yeah. So you can give both either PTU or carbimazole. You give beta blockers, preferably as smaller if available, so they will short acting, so that patient develop hypotension, you can pull it back easily. You want to give steroids, like we mentioned, we give to inhibit peripheral conversion. Which steroid to give, hydrocort or dexamethasone? There is a slight preference for dexamethasone if the patient has CNS manifestations. It is because dexamethasone crosses a blood-brain barrier, unlike our IV hydrocortisone. Then you give Lugol's iodine because you're trying to rely on the Wolff-Chaikoff effect to inhibit the deiodination at the thyroid gland. But you need to stop it after about 7 days. You might have other adjunctive treatment to help you, like lithium and cholestyramine. And if you're desperate, thyroid is still not controlled, you can do plasma exchange. Basically, you're just trying to remove whatever free T4 is in the blood, replace it with somebody else's blood who has normal thyroid function as an adjunct treatment. And early definitive therapy is important, RAI or surgery. So just to share everybody, there's actually an entity called Hashimoto's encephalopathy. It is presence of encephalopathy with high titers of anti-TPO, but it is a diagnosis of exclusion. So after you exclude everything, then the patient has high levels of anti-TPO, then it's probably that slight female preponderance. The median age is 48 years old, tend to be a steroid-sensitive condition. I've only seen once, but even that case also, I think neuro is not very convinced. Yeah. So this is the presentation of Hashimoto's encephalopathy. Most commonly presented with psychiatric manifestation like psychosis. Then the other possibilities would be patient presenting with seizures. The seizures can either be generalized seizures or a complex partial seizures. We became complex. You may say that partial seizures became affect consciousness as well. So in summary, treating thyroid storm and mixed edema coma, you really need clinical suspicion. It can be difficult if you don't have any prior history. And I've just shown you that some scoring systems that can help you make that decision whether it's a mixed edema coma or thyroid storm. So the other conditions I did not go through because in the interest of time. So calcium, hypercalcemia and hypocalcemia. So hypercalcemia generally, you can divide whether the patient is symptomatic or not, and whether based on the figure of the corrected calcium, whether it's mild, moderate, or severe. So in this study, a neurological manifestation occurs in about 30% of patients. So it can be like lethargy, confusion, or delirium, all the way to maybe even seizures. About 22% of patients actually have abdominal pain. Some have constipation, a lot have constipation. You know, hypercalcemia can cause pancreatitis as well. So if your patient with hypercalcemia got abdominal pain, you probably want to send that amylase to make sure it's not acute pancreatitis. Cardiovascular involvement, yes, hypercalcemia can cause hypertension on its own. It also results in abnormal ECG, arrhythmias, shortened QTc. And because hypercalcemia results in nephrogenic DI, patients with hypercalcemia often complains of polyuria. Yeah, and of course, if calcium level is high enough, it can result in AKI as well. So the treatment of hypercalcemia is aggressive fluid resuscitation. If it's available to you, you might want to start patient of calcitonin. So before I go there, if it's probably mild hypercalcemia, you can probably try fluids. A patient is severe hypercalcemia, especially the symptomatic, then you know probably you can give fluids will help you, but you probably want to give other things as well, such as your bisphosphonate, denosumab, and calcitonin. So the one that will really help the patient reduce calcium will be a bisphosphonate or denosumab. However, you have to know that the action of bisphosphonate denosumab take a few days to kick in. So while waiting for a patient to kick in, you want to buy time, that 2 days, 3 days. Aside from IV fluids, you give a calcitonin. Usual dose, you can start about 4 IU per kg every 6 to 12 hours, increase to 8 IU. But the problem with calcitonin is tachyphylaxis, meaning that you need increasing doses of calcitonin to achieve the same effect. So, but that's perfect. That 48 hours, 72 hours is perfect because it buys enough time for your bisphosphonate and denosumab to work. So fluids, give calcitonin to buy time so that your bisphosphonate and denosumab can work. So most importantly, of course, you need to identify and treat the etiology of the hypercalcemia. So whereas the other end will be hypocalcemia. When you need to know whether the hypocalcemia is acute or chronic or symptomatic. So if it's a chronic hypocalcemia, you can probably try more oral, especially if patient is asymptomatic. But acute symptomatic hypocalcemia, you need to treat it as an emergency. And I guess I often see it post-thyroidectomy, because we did thyroidectomy, there's an accidental injury to the parathyroid glands. So even slightly low calcium, 1.8, 1.9 is enough to make patient to have, symptoms and maybe even, cramps and seizures. Yeah. So the symptoms are paresthesia, cramps, carpal pedal spasm, laryngeal spasm, and bronchospasm, which can be life-threatening. You can do this CHOP-STAG sign and trosil, and ECG also show a prolonged QTc. So if the patient is chronic and asymptomatic, calcium is probably mild, more than 1.9. You can start oral treatment with oral calcium, as well as also activated vitamin D. Activated vitamin D will be our calcitriol or ROCK trial. In terms of choice of calcium, we often in KKM, we take calcium carbonate because calcium carbonate is the one with the highest percentage of calcium. About 30% of them are actually elemental calcium, as opposed to calcium lactate. Don't give lactate. Lactate, the elemental calcium is so low, less than 10%, 8, 9%. So you want to give something that gives you more calcium. So we usually go for calcium carbonate. Activated vitamin D is given because it helps to promote the absorption of this calcium through the gut to enter to the body. However, if the calcium is hypocalcemia is severe or patient is symptomatic, you need rapid correction. Often you give a stat dose or that 1 ml with dilute 50 cc or normal saline infused over 10-20 minutes. However, if you know the hypocalcemia is quite severe and you're quite far away from your 1.9, then you can actually give a patient an infusion. So one of the more common ways to create this calcium gluconate infusion is you dilute 11 ampules into 1 liter, which is 2 pints of normal saline D5. This results into 1 mg per ml of elemental calcium. Then we run about 50 mils per hour. Then you check the patient's calcium every 4 to 6 hours and adjust the rate of infusion based on it. But this is to buy time so that when you already start the patient on oral vitamin D and calcium. So while it's building up, you can buy time with this IVI calcium gluconate infusion. So remember, yeah, you need to dilute the calcium gluconate into normal saline or D5. You don't give pure calcium, very irritant to the veins, thrombophlebitis, extravasation can cause a lot of problems. So that's why maybe dilute it like that, you can still give through a peripheral line. Yeah. Okay, so for glucose, just quickly go through will be acute hyperglycemia and of course hypoglycemia events. So I guess you're already very familiar lah, what's DKA and HHS, diagnosis of DKA, glucose more than 11, pH of less than 7.3, bicarb less than 15, blood keto more than 3, urine keto more than 2 plus, HHS, patient must have severe dehydration, glucose is often more than 30, and calculated serum osmolarity is more than 320 lah. This is effective osmolarity, 2 times sodium plus glucose is enough. You don't need to add the urea. So quite commonly, you can see neurological manifestation as well. Because probably the patient is very dry, you can see mental obturations to poor coma. But I feel more commonly I see in HHS, especially sometimes I do see HHS coming in with seizures. Yeah, so when you have neurological manifestation, I tend to do a quick calculation of the serum osmolarity. Sometimes it's not just not DKA, it can be a mixed DKA, HHS. Like recently, I had a patient came in seizure, diagnosed DKA, but when you look back, actually the serum osmolarity was like 330. So it's actually a mixed DKA in HHS. So most common presentation is coma, followed by seizures. There have been reported hemiplegismus and hemichorea. You can have neurological deficits as well. Sometimes the patient can stroke out during HHS because the patient is so dry, the hematocrit goes up, there's hemo concentration. So you need to consider that as well. But if it's not because of stroke, it's because the seizure is due to HHS on its own. Often they have good recovery. So yeah, this is just to go through a case series of I think about how many cases, about 33 cases, I think, of neurologic seizures in HHS. As you can see on the far right, most of them have complete recovery, so that's good news. Okay, so this is also to say neurological deficit in HHS. Some of the case report, some patients can present with hemiparesis, but a lot of them also have good neurological recovery. I think it is because of the hemo concentration resulting in the poorer perfusion to the affected hemisphere, resulting in neurological deficit. But as long as you treat the patient aggressively enough, hopefully you can reverse that, ischemia. So about to mention will be cerebral edema. Cerebral edema is important, especially in children with DKA, and can occur in young adults as well. It's quite rare in older people. It's often due to the rapid correction in osmolarity. In the CPG, we wanted glucose to fall about 4 to 6 millimoles per liter. You want our serum osmolarity to drop to 3 to 8 milliosmol per kg per hour. However, the sudden drop of the osmolarity in the serum can result in the flow of the blood to the brain, which has a higher osmolarity because you drop it too fast. So some of the pearls that you want to consider is your patient capillary glucose can measure up to 33. So if it exceeds that, you say HI, send an RBS, because it might be 40, can be 70. So you probably want to use the RBS to monitor the drop of the glucose in the initial period first, because your capillary glucose cannot measure that high glucose. And then if the GCS drops during your management of DKA HHS, especially in susceptible patients such as pediatric population, then you want to do a CT brain to exclude cerebral edema. Okay, and then quickly go through will be hypoglycemia. Hypoglycemia for patients with diabetes, you want a way to divide the severity of hypoglycemia. It's called level 1, level 2, level 3. So level 1 is glucose as low as 3 to 3.9. Level 2 is glucose less than 3. And level 3, patient required, regardless of the reading, as long as patient require external assistance, it's called level 3 hypoglycemia. So this is only for diabetes patient. In patients without diabetes, you need to fulfill something called the Whipple's triad. The patient must have symptoms of hypoglycemia. And symptoms of hypoglycemia begins with, on the right hand side, you can see, starts with the sudden increase of the epinephrine. So patient has automatic symptoms. However, if glucose remains low, drop like maybe below 3, then the patient will start to have below 2 point something, the glucose will have neuroglycopenia. So for patients with non-diabetes, right, you can see that actually low plasma glucose often needs a glucose level of less than 3 millimole. So we often say hypoglycemia is when sugar is less than 4. but it's kind of arbitrary because in patients with diabetes, because of the impaired glucagon and they are so used to high glucose, they tend to develop symptoms below 4. However, in patients who are non-diabetic, actually patients' sugar about 3 point something is actually can be normal. You often see in young ladies, pregnant women, sugar of 3.5, 3.6, they're actually absolutely well, actually. So actually that's not hypoglycemia. So again, just a reminder, non-diabetic patients not only have a symptoms of hyperglycemia, they must have low plasma glucose. Don't rely on capillary blood glucose. It can be inaccurate when the patient is unwell. For example, I remember I saw before a case of Raynaud's, they thought capillary glucose, it was low, but poor perfusions to the hand, of course, will result in low capillary blood glucose, but the plasma glucose was normal. Yeah, so plasma glucose is required, and the resolution of symptoms when glucose is elevated. So just quickly go through some literature. The most common presentation of hypoglycemia will be this decreased sensorium, coma, stupor, obstination. Some can have behavioral changes, less commonly can have seizures or even hemiparesis. So okay, lastly, I didn't talk about pheochromocytoma because I thought it's just too much already. Just quickly go through adrenal crisis. So adrenal crises are actually adrenal insufficiency due to inadequate glucocorticoid secretion or action. So the key word here will be glucocorticoids. But it is important to remember our adrenal actually has 3 layers. The top, the most outermost part produce mineralocorticoid, middle layer glucocorticoid, and innermost sex hormones. So when you have the mineralocorticoid and glucocorticoid, they are actually controlled by 2 different systems altogether. Our glucocorticoids, our cortisol, is controlled by our brain from the ACTH. However, the mineralocorticoid does not rely on the brain, it relies on our RAAS system. So that's why in primary adrenal insufficiency, whereby there's a destruction of adrenal gland itself, you lose both mineralocorticoid and glucocorticoid. But when you have secondary adrenal insufficiency, that means you have, perhaps a pituitary surgery done before, your ACTH is low, you have glucocorticoid deficiency, but your mineralocorticoid system is actually preserved because it's not reliant on the brain. Yeah. So there can be a lot of similarities in primary and secondary adrenal insufficiency. So some of the similarities includes they can have hypotension. Why hypotension is because not only there's hypovolemia, but cortisol is actually important to increase the vascular smooth muscle sensitivity to vasopressor. So without the cortisol, the vasopressors do not work very well. Patient can have hypoglycemia, hyponatremia, sometimes hypercalcemia, and non-specific symptoms of lethargy, fatigue, GI symptoms, and so on. Yeah, so hypotension, hypoglycemia, hyponatremia, maybe a little bit hyperkalemia. So hyperkalemia occurs more in secondary adrenal insufficiency, primary adrenal insufficiency because you lose the mineralocorticoids. So secondary adrenal insufficiency, because they also lose the mineralocorticoids, the hyponatremia is often worse. They have hypertension, it's also often worse, but they can develop hyperkalemia as well. And in primary adrenal insufficiency, because ACTH is produced from the brain, the pro-ACTH, one of the breakdown, the other hormone propionate ACTH is actually the melanocyte stimulating hormone. So because we probably want to produce a lot of ACTH, a lot of byproducts, the MSH will be high, so they will have pigmentation in primary AI. So the neurological manifestations often can be very non-specific, like lethargy. However, because of the hypotension or change in electrolytes such as hyponatremia, it can result in more severe manifestations such as confusion, coma, and seizures. However, just remember that in adrenal crisis, manifestations are often non-specific. You do not need the presence of hypokalemia, hyponatremia, hypotension, hypoglycemia. You do need all to be present. Even 1 or 2 features along with the clinical suspicion is actually good enough to diagnose adrenal crisis. Really. So it is like for example, like what I mentioned in the thyroid, it is easy to suspect if the patient is already known to have adrenal crisis, adrenal insufficiency, but it's difficult in the ED level if patient does not tell you or patient is not known. So I think one of the most common cause was actually the traditional medications or exogenous steroids. If patient takes traditional medication or exogenous steroids for whatever reason, for example, rheumatological conditions, prednisolone and all, and they suddenly stop it, the body stopped producing its own steroids already because there was so much exogenous steroid. But you stop taking exogenous steroids as well. So they can result in adrenal crisis. So if you see the patient is Cushingoid, and comes in with hypotension, hypoglycemia, be very, very careful. Probably the patient has taken steroids from elsewhere and stopped it. That's why they develop adrenal crisis. So this is one of the more common things that I see. So they often have precipitating factor, most commonly infection, GI infections, because not only that the adrenal insufficiency results in hypotension, but because GI, you have hypovolemia because of vomiting, diarrhea. So these two things result, cause the hypovolemia to be even worse, and other infections also can cause adrenal crisis. So the management will be fluid resuscitation, treat the patients with steroids. So you can, upon making the clinical suspicion, you can send a cortisol, but do not need to wait for the result. Best to try to send cortisol before you start the treatment, but do not wait for result. Once you send cortisol, straight away start your IV hydrocortisone. So often we give 100 mg stat and then 50 mg QID. Why 50 mg QID is because a lot of studies shows that even at the most extreme state of stress, for example, patient in surgery, the requirement, the body's cortisol production is equivalent to only 200 mg. So that's why we give IV hydrocort up to 200 mg per day if you're treating adrenal crisis. You don't give like 100 mg TDS. But of course, patient have indication for that. For example, you say patient have septic shock or AEPA, feel free to give higher dose, of course. Yeah. And the thing to remember just now I mentioned in primary adrenal insufficiency, there's also mineral corticoid deficiency. So do we need to replace the patient with fludrocortisone? Not necessarily yet, because you can give the patient very, very high dose of IV hydrocortisone, 50 mg QID. So 40 mg hydrocortisone already have equivalent to 100 mcg of fludrocortisone, which the patient requires already. So you don't really need fludrocortisone if the patient is on this high dose of hydrocortisone. So after talking so long, I go through quite a lot of things, but so in summary, endocrine emergencies can present with neurological manifestations because endocrine hormones, affect the whole body. So I think the most important thing we talked about earlier would be pituitary apoplexy, the constellation of severe headache, vision disturbances, as well as ophthalmoplegia. Do imaging, start IV steroids, refer endocrine and surgeries. Clinical suspicion of myxedema, coma, and thyroid storm is important. You can use certain scoring system to help you. You can send a TFT. Don't wait result, you treat first. Don't forget steroids for myxedema, coma. Yeah, thyroid storm we give steroids, but myxedema, coma also needs steroids. And then for the others, any neurological manifestations, you always consider electrolyte manifestation. Very easily, you can send for the patient's RP, calcium, and so glucose. And this already will give you a clue whether it could be DKA, HS, or hypoglycemia, hypercalcemia, hypocalcemia, or sodium would be probably, would say, adrenal crisis or not. So that would help you. Yep. So I think that's all. Feel free to ask any questions. Thank you.
All right. Thank you, Dr. Chew. I believe even though endocrine emergency is more common to be seen by us in ED, but I believe there is a few new things. Okay, for me personally, pituitary apoplexy is something which is not common that I see, or perhaps never see, or that never diagnosed myself. And then surprisingly, there is a scoring as well for myxedema, coma. All this while, we only know Bush-Watowski scoring for hyperthyroidism, but I'm not aware that there is also a score for myxedema, coma. All right. Okay. Perhaps I'll open the floor to the participant to ask Dr. Chew any questions.
Hi, Chew. Good afternoon, Nasrina here.
Hey, hi, Nasrina.
Hi. Thank you so much. A very interesting presentation. Okay, I got 3 questions.
Sure.
Is it okay if I just go through all 3? Then you can answer?
Can.
All right.
Sure.
Okay, it is a surprising thing for me to know that there is a role of dexamethasone in a condition whereby you have thyroid storm. I thought it's always hydrocort. So just in the case of where you have adrenal crisis, which one is preferred? Is it dexamethasone or hydrocort? And is there any differences if you start any of it? That's one.
Sure.
And number 2, before, let's say we suspected a patient comes in with probably myxedema, coma, or probably with Addisonian crisis, will be helpful for us to take a serum cortisol, random one, so that you guys can, probably it can become a reference to the endocrinologist later on. And the third question is a little bit more basic. I'm always confused, when you're calculating for the serum osmolarity, 2 times sodium plus glucose. Now we can omit the urea. Does the sodium need to be a corrected sodium, or is it the sodium that you have from your lab? That's all. Thank you.
Sure. Thank you, Nesrina. Okay, so let's go back to the first one. First one was again the I lost track already. Dexan and hydrocort, yeah. So yes, I also often use hydrocortisone, but I didn't realize that dexamethasone used quite extensively, especially in UM. When I was in UM, they like to use dexamethasone quite often. And I guess it doesn't matter as long as you use a potent enough steroids, because the whole idea is to inhibit the peripheral conversion of free T4, T3, so any steroids would do. However, in adrenal crisis, it's slightly different. Hydrocortisone has glucocortisone activity, as I demonstrated earlier. So if you have primary adrenal insufficiency, you want to replace both glucocorticoid and mineralocorticoid. Hydrocortisone is good enough. The high dose is good enough to replace both. However, dexamethasone does not have any mineralocorticoid activity at all. So if you give it for primary adrenal insufficiency, your dexamethasone can cover the glucocorticoid, but it cannot cover the mineralocorticoid deficiency. So that's why often we give hydrocortisone, because you can replace both. Of course, theoretically speaking, if it's a case of secondary adrenal insufficiency, pituitary cause, or maybe due to exogenous steroids, technically you can still give dexamethasone to the patient. It should work, but because of that, we just give hydrocortisone to to those patients. Now the second one was what already, Nisrina? Sorry, I short-term memory loss.
The random cortisol before starting.
Yes. I would say, yeah, thank you for sending. Because it is true, cortisol result, we don't really have a reference range out of the morning. AM cortisol, we always say a result between less than 140 is low, a result of more than 500 is adequate, anything between is indeterminate. However, at other points of time, in the afternoon, in the night, we expect it to be lower, but we don't really have the reference range. So that's why in an outpatient setting, or when the patient is stable, we tend to do it at AM cortisol rather than random. However, in the case of emergency, obviously I cannot wait until the next morning to take my AM cortisol. I need to give the steroid stat. So if you send for me, that would be very, very helpful, because I can just look back at the result later on and I say, oh, actually the cortisol before this, actually like 2000 is really so adequate already. So patient have adrenal insufficiency, I stop it. Or before you started your steroids, I check back, oh, cortisol is already 50, is extremely low. Patient already confirmed to have. If not, if you start the steroids and I don't have the cortisol to refer, I had to slowly taper down and do probably a selectin test before the patient discharged to this site. So yes, if you do send the AM cortisol with a random, also is fine. Before starting a IV hydrocort, it would help me a lot. So yeah, thanks. And then the next one would be your corrected your serum osmolarity. We do not correct lah. We take the lab results ×2 and plus the glucose.
Thank you so much.
Thank you.
All right. Okay. I would like to take this opportunity again to thank Dr. Rawati and also Dr. Chew for your participation, for the excellent presentation and nice discussions about the cases of rheumatology and also endocrinology. Okay, hopefully we can have further collaborations again in the future with that. Just for the information of the audience, our Neuro SIG group has planned few other activities this year. As you all know now, news Neuro Emergency Webinar Series, which is every 3 months. I think next we're going to have our Nexus Neuro Emergency Exclusive Update Series. I think this is for this year, it is about management of epilepsy. And then I think later on this year, we plan to have EMINEMS, Emergency in Neurological Medicine Symposium. On top of that, we're going to have our Emergency Neuro Life Support. The next activity will be in Tawau, I think at the end of February. Hopefully all of you will have an update from our group, and then hopefully you can join as well for our activities. Okay. With that, saya serahkan balik pada Nasrina. Anything
Dr.
else you want to
actually, there
announce?
is one question for Dr. Chew.
Oh yeah,
It's
yes,
inside
yes.
the
Oh, okay.
box, yeah.
Yes. So I think thank you for your question. Yep. So Yep is trying to ask me, is there any a clear definition between thyrotoxicosis and thyroid storm? Because in a lot of patients, patient is uncontrolled thyrotoxicosis, we can see that the Birch-Rhodowski score is high. I absolutely agree. It can be very tricky, isn't it? You calculate anybody, also Birch-Rhodowski score will be high. But in a way, if you want to define thyroid storm, it should be the thyrotoxicosis starting to result in target organ damage already, complications, for example, starting to cause fast AF in failure, start to cause the patient to have, CNS manifestations and so on. So I feel if you calculate Birch-Rhodowski score is high and you can't decide, it's okay to label as thyroid storm first, refer to the medical and endocrine team, then we will decide from there. Sometimes I feel there's alternative cause. I don't think it's thyroid storm. I do off the impression, but if your Birch-Rhodowski score is high, you cannot decide. I think it's always okay to err on the safer side first. You can just giving patient a little bit extra glucose and steroids, not really harming the patient in that sense, I feel. So you refer to us, we will make the decision for that. Thank you.
Okay, thank you again for the answers. Okay, Nasrina, anything else? Any other announcements?
No, I think I stop recording now.